I would request again Dr. Tayyab Sab to come and present the role of radiation protection and the radiation hazards in Cath Lab. So till then, we'll fix the problem, inshallah.
अस्सलाम वालेकुम एवरीबॉडी। मेरे ख्याल से इतनी दफ़ा मेरा नाम लिया गया है कि अब मेरी टॉक हो ही जाए तो बेहतर है। तो आई स्टार्ट द टाइमर क्योंकि मेरी टॉक थोड़ी सी लंबी है क्योंकि उसमें थोड़ा सा बेसिक साइंसेस का एलिमेंट भी है, तो होपफुली विल फिनिश इट क्विकली एंड ऑल ऑफ अस विल लर्न समथिंग। So till they bring it up, so radiation is not as sexy as TAVR or CTOs or doing bifurcations, but it's something that all of us deal with every day. And it involves everything and all, as our senior colleagues have mentioned, having a heavy foot. Can you get the slides up here? I could see them here. So we deal with it every day, and the worst thing is we don't see it, we don't feel it. It's not like a nail in your foot where you will hurt and run to a doctor or somebody that you'll cry. But it affects all of us on a daily basis. Doesn't matter whether you're a structural operator or you're doing a left main PCI. So we need to know a few things about it, and I think our fellows or trainees need to know about it, and I'm still learning about it. And when we are doing the cases, at that point, we are not thinking we're doing a lateral view and the tube is just next to me, because you're just worried to get that stent pushed in to cover the lesion or cover the dissection. But it will affect all of us in 10, 20 years, and some of our senior colleagues, it may have affected already. So I guess the delay is still there. I can do it, sir. Any command from Pak Army, we have to follow. All right, we'll start. So radiation, basically, we are worried about ionizing radiation. There are two kinds of radiation. One is non-ionizing, one is ionizing. Ionizing radiations, non-ionizing are the ones we see in our cell phone, radios, microwave. Ionizing radiations are the one which can knock out an electron out of an atom and make an ion out of it. That can penetrate things. It's usually three types: alpha, beta, and gamma. Gamma are the ones which we are worried about because it can penetrate the tissue, the human tissue, but it cannot penetrate the lead. So all of us should be worried about these gamma radiations that we use. In Cath Lab, for the most part, that we are worried about is the scatter radiation. So all of us know the Cath Lab setup. Dr. Khalid just mentioned there's something called II, that stands for image intensifier, and then you have an X-ray tube at the bottom, and then there's a patient in between. Here we go. So we are back in business. So I'll just quickly fly through this. This is the outlay of my talk: quick ABCs of X-ray, occupational risks in Cath Lab, radiation safety basics, and then finally optimizing radiation safety in the Cath Lab. I want to save most of the time for the last section. That's the most important in the practical. So alpha, beta, gamma, I told you about ionizing. I told you that the gamma radiations can go through the body. We talked about scatter radiation. That is what we are worried about in the Cath Lab. So few terms here. Well, my clock started at 7 minutes, so it's not 10 minutes. They just started at 7 minutes. Anyways, so exposure is measured in coulombs per kilogram. Biological effect, that is the equivalent dose, is measured in sieverts, and the absorbed dose is measured in gray. So what is the difference between a gray and a sievert? They're very similar. It's just that the sievert takes into account the biological effect. So the biological radiation dose would be shown by the sievert. So this gives you an example. A chest X-ray is 0.02 millisievert, while a regular coronary angiogram is 7 millisievert. So that's about 350 chest X-rays. And a nuclear stress test is 9 millisieverts. If you were doing a big-time CTO case, that would be about 81 millisieverts. That's like 4,000 chest X-rays. So a lot of radiation exposure. This is just to give you perspective what we are dealing with. Inherent about, we get exposed to 2 millisieverts every year, if that's in North America. Per year. So interventional cardiologists get exposed the most amongst all the physicians. So that is about 250 to 3,000 chest X-rays. Our left side of the body, since we are standing on the right side of the patient and the equipment is on our left side, gets exposed most. And there is a study that showed that they get most of the tumors that happen in the physicians, whether they are IR or interventional cardiologists, happen on the left side of the brain. Other risks are cataracts, orthopedic strain, and cancer. and knew quite a few of my senior colleagues who do have back problems all the time. And cataracts are fairly common if you're not using those lead glasses. And the worst thing, as I said, is I don't feel a thing. You can't see radiation. You can't feel it. So that's why we are dealing with it every day, getting exposed to it every day, but without having much information about what the consequences are. I did mention about the biological effects that the radiation cause. Now, there are two kinds of them. One is deterministic, that is dose related. The other one is stochastic, that is probabilistic. So the deterministic effects are hair loss, skin damage, tissue necrosis, cataract sterility that you see oftenly in few months, years' time. Stochastic are not dose related. This is something that the patients will, the doctors or whoever gets exposed will develop cancer and will have genetic defects. So this is an example. This is a patient who received about 11 grays, and then this is a patient who received 18 grays and developed skin necrosis at 6 months. It's a very standard procedure outside in Western Hemisphere where the patients used to get those AFib long ablations that the hospital will know if they get excessive radiation. They will give them a call every few weeks to check if they have developed any skin radiation deterministic effects or not. Stochastic effects are a little different. Here, you'll have a DNA damage, and then that may develop into a cancer cell and subsequently tumor cell. There's no way to predict how much radiation can cause this. These are few numbers all of us are familiar with. A lot of Cath Lab softwares have it. One is a fluoroscopic time, other one is AK air karma, and third one is DAB dose area product. Usually, I'll just quickly run through them. Fluoroscopic time, it's not one of the best measures of the radiation exposure because it underestimates. It does not include the sign angiograms. Air karma is the cumulative air karma is a measure of X-ray energy delivered to the air at the interventional reference point. The interventional reference point is 15 centimeters from the isocenter, and I'll show you where those 15 centimeters are. And dose area product, it does show what the dose burden is, and it's a good indicator for stochastic measure. So air karma is for the deterministic, and this is for stochastic. So air karma, if it goes really high, the grays will have to be worried about if the patient will get a skin burn or not. And this is the isocenter that I was talking about, 15 centimeter from the tube. So radiation safety basics. So three things we need to worry about. All of us, we know we need to find out that if the procedure is justified, meaning the patient would benefit the use of this radiation, will benefit from getting exposed to this radiation. And then optimizing it. Optimizing it, we know ALARA, that is as low as reasonably can be achieved. And all of those measures I would talk to you in the last section of the talk. The numbers that we use usually is about 20 millisieverts average over 5 years or 30 millisieverts per year. That is when the radiation department will start reaching out to you and asking you, hey, your radiation exposure is going up. For the extremities, it's a little bit more than that. So now this is the meat of the talk, the optimizing the radiation in the Cath Lab. All of us are familiar with dosimetry badges. Mine is usually lying somewhere in the corner of the Cath Lab. But it's very important. And what does it show? It shows us absorbed dose, equivalent dose, and effective dose. Better to have two dosimeter. Actually, it's not better. You should at least have two dosimeter badges. One should be above and one should be underneath the lead apron. And that tells you about the deterministic and stochastic effect. And they should be checked every so often. Whatever is the protocol in your Cath Lab. Could be 15 days, could be 30 days. Most of the Cath Labs would do 30 days. Now, you can get a monitor like this that can give you a real-time monitoring of the staff dose in the Cath Lab. That could be reset per hourly, or you can figure it out for a daily basis. Not too many hospitals have it. I don't know in Pakistan, but even in Western Hemisphere, not too many hospitals would have this day, which it would tell you this is the millisieverts you have received in per hour case. Very important slide, I would say everybody to pay attention. This is the ideal position. The patient should be closer to II, far away from the tube. Here you have the II down and patient relatively closer to tube. You get more radiation. And if you're closer to tube, that's where the worst part, if you're closer to tube, you will get the most radiation. So away from the tube, closer to II is the best position for you to get the minimum exposure to the radiation. Thin versus thick patients. All of us know that thick patients would give you a whole lot more scatter. And it's a habit that all of us would tell the tech, hey, bring the table down, get the II up. So you can get the most of it in the field. That's bad for you. Get the patient up closer to the II, away from the tube. Even if it's a thick patient, it's better for us, less scatter radiation. Less angulations. I know my colleague Dr. Khalid mentioned about all the good angulations, but the more the angulation, the more the radiation exposure. And you could see that if you have a plain AP straightforward, it's 20 to 40 milligrays, while as compared to angulation, the radiation goes exponentially up. Of course, we have to do angiograms, we have to put in stents and have to find the optimal views, but as minimum angulation as you can do. FOV, very important. Larger your FOV, the better it is. So at 25 centimeter, you are 0.3 milligrays per second. At 12 centimeter of FOV, you are 1.23 milligrays. So we are used to like bringing all those FOVs down, having the magnified views to enhance if the balloon is inside the stent. It's important. But just imagine that your radiation exposure goes significantly up. Collimators. Do remember to use your collimators. What is this? This is a lead shutter that is attached to the beam exit port of the X-ray. And it can limit the source of the body that's irradiated. You could see here, you could see there are lungs there is heart there. Now we don't need to do chest radiography there, you need to burn those leads. Bring all those collimators in and you could see only the heart. So open beam and collimated beam is gonna make a big difference to your radiation exposure. Again, moving your II or in the tube every so often. So this is a patient who received at a single place 30 minutes, and here the Karma Air products was 1500 milligrays. While the same patient, you're doing 15 minutes here, 10 minutes there, 5 minutes here, same Karma product, but the deterministic effect for this one or the skin injury would be a whole lot less. So especially when you're doing CTOs or our EP colleagues who do these AFibs, keep on moving their IIs. Pulse fluoroscopy, very important. Again, if you drop down your pulse rate from 15 to 7.5 frame, the radiation goes down by 67%. So our machines vary from 7.5 to 30 frames. We used to do LV grams on 30 frames in America, but I think that's a whole lot of radiation we are getting exposed to. Again, if you're doing a left lateral position, it's a really bad position to be in. You need to make sure there's a screen there. So you can well imagine this gentleman standing here next to the tube is getting 18 milligrays per hour, while this is an AP position where you are getting barely a 1 milligram per hour. So if you have to do it, this is a no-no. Your shield should be in between when you are doing a left lateral position because you're getting the most exposure at that point in time. As our senior most colleague here, Colonel Saab just mentioned, you need to know about your foot. Heavy foot syndrome is a big issue. You need to use last image hold, safe fluoroscopy, all of those things will help you considerably save radiation. You need to know your shields. Most of the cath labs will have 2 to 3 these shields present in the lab. Sometimes this one is broken, but I have seen most of the cath labs here would have this one, and you need to have this one between you and the equipment. You need to take care of your lead. This is your armor that you wear to battlefield every day. So if they are like this, they will be cracked. And then there's a certain way you need to get them x-rays and everything. Zero gravity is coming. A lot of places have it. I don't think we have it in Pakistan. Core path is there. This is help in EP for ablations. So just pay attention to these last 2 slides, even if you haven't listened to me in the past, last 9 minutes. So the important thing, avoid heavy foot, minimize use of sign, avoid angulations. LAO and AP cranials are the worst views. Use them if you have to. Try to increase the FOV, minimize the magnification mode, use 7.5 frame, and then keep the subject closer to II, away from the tube, and then use the collimation as much as you can. And if you can buy that thing to monitor the radiation on an hourly basis, that would be really good. Take care of your lead. Again, maximize the distance from the X-ray source. That would be very important. And keep all the shields that are in optimal place. Keep all the body parts out of the view all the time. And we are getting access, putting our hand in the femoral part and looking at the needle, keep it out. Keep the table height as much as possible, and every 30 minutes, move the beam. So this is our A+ cardiologist, A-star. If you see him, it's in AP position. There are collimators working. There are shields there. He's wearing lead glasses. So we should be all these A-star cardiologists as compared to radiation. Thank you very much for your time.